have those. I have some today, right? So then it's like, so then, because if I don't eat that, then I'm out, because everybody else is being able to eat gummy worms and bears and lollipop. I mean, whatever, you know. Rice Krispie treats, clearly those are my favorite. I haven't had one in a long time, so that must be where that's coming from. And I'm talking about diabetes, right? Okay. So I'll get back on track. Sorry. So anyway, so you think about that push-pull around belonging, right? And how impactful that is for kids, right? So now, when you think about some of the challenges that these children and adolescents do experience, it's because the treatment regimen is very intense, right? You're talking about having to check your blood sugars maybe 5-6 times a day, depending on what happened. It might be more if you're low, if you ate something. You need to either check before you eat or after you eat, depends on what you ate, those kinds of things. That's a lot. And it's also depending on how the insulin is administered. If it's by needle, that's a shot every time, no matter what you're putting in, right? Now they've got the pumps, which make it a little bit easier, but they still kind of have to do sort of like a port. So it's like they have to change the site, but it's not doing the needles every time they dose, but they still have to do the port, and that's where it goes, and then they change sites because, you know, the areas, they get sensitive, right? So there are these parts. Then you lump in, well, but you kind of have to stay on the straight and narrow path about what you eat. And then if I'm an adolescent, then I'm worried about, my friends are going to get pizza after practice. Or, let's back up, practice. Oh, you want to play a sport? That takes some attention too, right? Because physical exertion, that's going to drop your blood sugars. So you have to make sure that you're dosing appropriately before and after, so that you don't like fall out on the field, right? So like all of these things they have to attend to, that people who don't have it are just kind of like, yeah, well, no, just drink some Gatorade. Do you know what the principal ingredient is? Like, I mean, so it's like all of these places where, you know how sometimes we think about the areas where we have, where we're subjugated or we have power and privilege. Health is one that if you've not had an issue around health, that never enters into your way of thinking. Because you're like, no, what do you mean? Like, why do I have to worry about what's on the menu to eat? Or do I have to worry about how long I've been out? Do I have to make sure I carry enough insulin with me in the event, you know, I had a flight delay? And not coming here, but the trip before, and because I've had some, interesting enough, I had some health issues that caused some weight loss for myself. So when Darren was talking about that, I was like, oh, this is interesting. I wanted to chime in, but I said, I think this might be inappropriate. So I held it to myself. But now I'm telling you. But as I thought about that, you know, it was something like that around, what if I didn't have enough medication? What if I were on standby and I missed my flight? Like, what I would be like, oh my gosh, like somebody has to get me to a pharmacy because I only had, like, I don't think I would do this, but like, I only had enough because I knew I was going back, right? Sometimes when we think about those kinds of things, trip interruptions or anything could happen. We were doing, and I know this is random, but it's one of those experiences that at my job, they were talking about what would happen if there was a tanker spill that required our building to be shut down. So, to give you some context, we're in the 15th floor in a high-rise in the Loop in Chicago. So, if the train goes off track, which is very close to where we are, they shut down everything. Nobody in or out, which means you can't go out the building. if I am expecting I go to school and I leave and go home, I'm not bringing necessary medicine with me because I'm not thinking that I'm going to need it. So it's like even in thinking about those kinds of things around your health, that you don't think about the what ifs, right? Because you're reasonable health, and why would I have to think about that? I don't have to think about what I eat. I don't have to think about if I don't eat. Like I've got to be able to carry something with me to make sure my blood sugar doesn't drop. Like I just can't say, oh, let me go get a Snickers bar, right? Because that's what you eat when you're hungry, right? So like those kinds of things, when you think about what the dominant narrative says about what is accessible to you when you are normal, when you don't have health issues, right? So now, goals of treatment, all right? Like I said, the very first, the first two, one is to the hemoglobin A1C being less than 6%, but the first one is like, you gotta maintain treatment adherence because what happens is if you don't, you face complications later in life. So you're talking about problems in microvascular or in macrovascular. So if any of you know anyone who was older, who had type 2 diabetes, that they didn't manage well, they could potentially lose their eyesight, they could have amputations. It starts with a toe. And usually when they do the toe, it just continues up the leg. Kidney failure, because it causes problems with your blood vessels being able to transport blood. So you have more problems. Heart disease. I had a great aunt who, she was kind of like your grandma, probably a little bit worse. Because I actually was dueling, like my grandmother and her sister, so my great aunt. They both had type 2 diabetes. And the church, right? We go to church, we have the dinner after church, and of course, everybody's got those like lovely cakes that the mothers of the church made that are from scratch. That's not a box cake. I don't know if some of y'all might not know what that is, but these are like homemade. That this is it, and you're like, oh wait, I'm not eating food. I'm actually having cake. That's what I'm having. And so I would watch them and feel somewhat helpless around their choice because I was a teenager, and so how was I supposed to tell my grandmother or my great aunt, you can't have that? What? No, that's not appropriate. That's disrespecting my elders, and that's not what we do. Like, you cannot do that. Like, if she said, go get me 2 slices of that cake, you better walk your butt over there and get 2 slices and wrap it up so that my father didn't see it. Yeah, so I'm complicit, right, in the deception, but what do? Because then when my father says, what were you doing? Grandma said, right, because Grandma said, she wanted me to get that for her to, and I was like, what am I supposed to do? It's Grandma, like, I mean, I can't tell her no. Yes, you can. No, I can't. That's your mama. Like, no, I know my place. That kind of thing, right? So it's like you get those, and I can't imagine what that's like when you are a young child and your parent is doing that, and you know that that's not what that should be like. Even, and it doesn't matter whether it's diabetes, it could be any other medical issue, right? And they're doing something that you know they shouldn't do, but then you feel like, well, how do I engage, and how do I kind of push back, and just, will this impact my relationship? Will I be out? Because I thought I was the favorite. So I'm trying to mess that up, so, because she made great banana pudding. So I wasn't like trying to mess up like that piece, like because I was connected to her in that way, right? So thinking about how not only relationships between the generations get impacted, but sibling relationships, right? So how does that play out amongst your siblings? Because I feel like my grandmother and my great aunt were in a competition around who could eat the most, things that would impact their sugar. I know that sounds weird. But I mean, of course, I'm thinking about this now as a therapist, like watching what I saw, and it was about attention. Because if the blood sugars were elevated, my father would have to do something, would have to say, okay, what did you do? Oh, we're gonna have to do this. So an elevated blood sugar actually meant more contact with my dad. All right, now we had a family therapist. You know, I wasn't one then, so I'm out the hook. But if we had one, like those would be the things that I hope that they would be attending to be able to say, let's kind of talk about this. Like, are there ways that you can actually get connection without it being tied to like your health not being good, right? All right, so also other forms of, other goals of treatment that you want to do everything that you can to delay or prevent any kind of future complications. You also, and so these last three are ones that I'm more inclined to focus on, that you want to promote positive coping strategies, both for the normative and disease specific, okay? Because normative stuff, you know, I'm an adult. No, I'm still a kid. You can't expect me to do that. That kind of back and forth of the adolescent. Then, what's happening for the disease-specific coping? Like, I know it sucks to have to do these. Like, I know you're tired of doing finger sticks. You've been doing them for 15 years. Yeah, I would be tired of that too. So it's like that ability to help them develop some more positive coping around how they're going to manage that. Excuse me. Reduce the stress related to the disease. That's also important. And for the most part, this is like the prime goal, right? To improve their health-related quality of life. Because the quality of life has five constructs, right? So they look at social, emotional, physical, and I'm missing some others, but I think it's 5, right? They look at these 4 or 5 areas to see where are you actually in some good place, right? Okay, so medical family therapy. Did anyone take a class? Oh, last week. Oh my goodness. Yes. All right. So for those of you who might not know what kind of like the definition is, I've provided it here. So the biopsychosocial treatment of individuals and families who are dealing with medical problems. Now this came out of McDaniel, Hepworth, and Yorty in '92. They actually had an updated version, came out in 2014, which I did the one from at the bottom. So when you think about what MedFT encompasses, it's the biopsychosocial spiritual perspective that you use the systemic focus to work collaboratively, right? So those are the 3 points, right? So it's the biopsychosocial spiritual, systems, and collaboration. Those are the hallmark of MedFT. We know as systemic thinkers that you can't just focus on one aspect of the problem, right? We know that there are multiple things that are involved. And so when you think about someone who has type 1, it's not just that they've got type 1 diabetes. There's some other contextual factors, like where do they live? What is their SES? What gender? Because gender will have an impact on how they are experienced, right? Do they have any spiritual beliefs? What does their community belief say? Those kinds of things. So they're embedded within a community, and we have to be thinking about how do we put all those pieces together to make sense of not just them, but them embedded in their own system. Because they've got the patient who's in a family, but then the family is embedded in the medical system, right? And there's a very different way that we think, right? Therapists are saying, it is not cause and effect. We're circular causality, right? Medical is saying, I'm sorry, no. If you eat poorly and you consume a lot of salt and you don't exercise, you will develop hypertension. If you happen to have diabetes and you do those things, your A1C is going to increase. Not really interested in some other things that happened that influenced why you ate what you ate. All right? They're just looking at, you did this, and so this is now where we are. And so this is how we're going to fix it. The way we fix it is we address those things that we identify as the causes, right? But that's not how we think. So, 2 important points with MedFT is that there's a focus on agency and communion. Now, you have to think about this from a culturally responsible perspective, because when we say agency in the United States of America, let's put it at that, we think that you should be able to stand up for yourself and be responsible for your own care and treatment, right? So you should be able to go to your doctor and say, this is what I need, and if you don't feel like things are working together, that you can have a conversation with your physician and say, I don't know, feeling like this is happening, is there something else we could do, right? Well, given the culture of medicine, agency is usually not encouraged by medical professionals, right? Now, this is not, all. I have a very good family doctor. She takes time with me, which I appreciate, which is why I'm still with her. But she's somebody who will say, even before asking me what brought me in, she says, well, but how are you doing? What? Say, are you sure you're not a therapist? Like, she is fantastic because she wants to know about all these other areas of my life, because she knows that I'm in the process of the dissertation, and she's like, so how's that going? And I'm like, you remembered? Oh, yes. So, so she's thinking about those things. So I could ask her challenging questions, and she would be okay with that. Some doctors are not okay with that. Some doctors are kind of like, who are you talking to? Like you're questioning, like what I say? Like, do you know how many years I went to school? Like, I mean, and it's like, okay, so it's like, I know you have a skill set, that's not my skill set, but I have a question, and I'm curious about this, and I want to know, like, something is not adding up to me, and so I'm trying to get more information. Or if you're on the other side, and you're with a parent, or you're with a grandparent, and then you're like, okay, but I think we're missing, like they're not getting this, and so I want to ask some clarification questions. Some doctors are not really open to that. So as a MedFT, that actually is the place where you kind of insert yourself, right? That you almost are the translator, that you can be the go-between, that you can get the medical doctor to actually hear what the patient's concerns are, and that you can get the patient to be able to voice what their concerns are to the medical doctor, so that you can kind of like help them with that conversation and the communication. communion. Now this is something that we would all be able to connect with, right? It's your sense of being loved and belonging, right? So I would say that families would come to the clinic and may have a sense of communion with themselves and with their community that they are from, but that might not necessarily translate to a sense of communion that they feel in the medical establishment, right? Because if they feel like, I don't really fit here, I'm just coming to get care and treatment, you know, I don't know if these people really care about me as a person, I'm just another patient. You know, so like, how do you help them develop a sense of communion, not only maintaining that within their own families, but to develop it with other medical health professionals. So now, these are the techniques that we're kind of refer to. And so there are 7, if I counted correctly. Yes. And so I'm going to briefly talk a little bit about them, but then we're going to go back to the Miller family. Okay? So, one of the things that I noted earlier about recognizing the biological dimension, like you have to, it is a disease. A disease is present. And so you have to acknowledge that there is something wrong, right? Not that we're not sure, but no, there is a disease. Now, how do we develop the context around this person having this, and then what it looks like, what it means to the individual, what it means to the family, and then how they are then viewed by the medical establishment, right? Solicit the illness story. So like I said, narrative is a perfect fit for this. Now, if you're not a narrative family therapist and you're doing medical family therapy, doesn't mean you can't do it. We'll just have to chat about how you do it. No, I'm just joking. Narrative is really a natural fit to it because you want to have these conversations with your patients about how they're making sense of where they are right now, right? Because there's everything that informs that. Their own, if you're talking about a kid, their parents, how they make sense of illness, health, what is their own experience, what's happened in the past around that. You know, when you get into, this is a really good example. So when you think about end-of-life issues or someone who is at a place in their disease where they now have to be in palliative care, which is like there isn't anything they can do. It's only like things to keep them comfortable, right? So usually pain medications and things like that. So how do people make sense of, so if my experience with that is that, no, they're not supposed to stay in hospice, they're not supposed to stay in the hospital, they're supposed to come home. Like, no, they shouldn't die alone, they should die with family. But what if that is not the other person's experience? And they're like, what do you mean? No, they should actually stay in the hospital where they can receive care. Like, you can't care for them at home. And so there are these, like maybe their parent before, this is what happened to them. And so they're informed by that way of thinking. And so when it comes to what care should look like for their kids, that's what lens they're looking through. They're looking through that experience lens around, this is what happened to my family member, my sibling. And so, no, I don't think that's appropriate, right? So getting to the understanding of how they've actually connected these things. And one of the most powerful things to do with these patients is like, and this is what I would do, I'd have to be kind of strategic about it because when you're a medical family therapist, sometimes you only got 15 minutes, right? So how you think about like the 50-minute hour doesn't really work. And so when you ask questions about where they are and how they've come to be at that place, it's amazing how many times that they must have told their story about how they got there. Because when you say, so can you tell me a little bit about this? They're right into it and you're like, man, like that, I mean, you hit that almost in 10 minutes. And you're like, wow, that was I mean, because they can cram a lot of information in. Like, even if you did something specific like, so do you remember what was happening when your child got diagnosed? They can take you back, tell you what was happening, you know, maybe even what people were wearing, what the doctor said, what they remember, what they don't remember, things that came up later, those kinds of things. And so it's then helpful for you to be able to piece some of those things together. So why might they have a not so great relationship with the doctor? Maybe when the diagnosis happened, they felt like the doctor was blaming. And they've been kind of holding on to that for this whole time. And so then whenever the doctor is saying something, they kind of like, okay, whatever. And you're like, I don't understand what this is about. Like, what's happening? And then you find out, like, oh, that's what this is about. So then, you know, you've got some relationship repair to do between the family and the clinician. This third one is a very key one, because when you think about when people arrive at the places that they are, whether or not it is applicable, when their children receive a diagnosis of type 1, there may be a sense of blame. Like, somehow I caused this for my child, right? Whether it's reasonable or not, that's how they feel. And you have to respect that. You have to respect the place that they're in at that moment, because you can't go in and say, well, no, you should, well, why do you feel like you should be blamed, without understanding where it's coming from, so that then you can go back in and kind of like, oh, okay, well, how about consider this, and what about this piece? And then finding out more information so that you can help them not get stuck in it, right? Because that's a defense. Taking the blaming stance, accepting blame, being responsible, feeling guilty, that is a defense. Not really a good one, but it's one, right? So you have to be able to help them work through it. You can't pull it from them before you give them something else, right? Because then they're left defenseless. And that's not a good thing, right? Because then even their fallback, you kind of taken away from them. So you've got to be able to give them, to respect what they have, and then start to work around it to say, okay, so can we consider, is there room to think about this differently, right? Communication is key, right? The amount of miscommunication that happens in situations like this is tremendous, because if all of the people who are involved, if you hear one thing over here and then you hear one thing over here, and you're like, okay, but this person said so-and-so, or this doctor said this, or but the nurse said this, oh, but the diabetes educator said this. What are we supposed to do? Like, because I feel like these are 3 different things and I don't know how we're gonna do this, right? And so being able to be the bridge of communication for families and physicians is important. Very big developmental issues, you have to attend to them, because the thing that works for the child who was diagnosed at 5 is not going to work for the one who was diagnosed at, let's say, 18 months. What are the expectations that you have for an 18-month-old? They cannot do anything but sit there and look cute and get into trouble, right? That's all they can do. A 5-year-old, they can actually tell you when they don't feel well, right? They have words to be able, they might be a little off on what it really means, but they usually can use their words to tell you some things, right? And so you have to kind of look at how you do treatment. If you've got a kid who is about to go off to college, you have a different conversation with them than you do the kid who's about to go into high school, right? And physicians have to realize that how they talk to them and what they can expect of them will be different. Because it's almost easier before kids hit adolescence. Because there's something about that transition, right? When you've got little kids, you know, the parents can say, no, no, this is what you're doing. And they do it. All right? That shift, like, no, but I should be able to do things on my own. Like, I'm about to be an adult. Yeah, but you're about like 4 years from that, so no. So it's like the navigation that has to happen around what you can expect them to be thoughtful about. Because when you ask them sometimes why they did what they did, and they say they don't know, it's true. They don't know. I mean, because that part of the brain's not fully developed yet. It doesn't really happen until you're 21, right? The executive functioning center, right? And that's why you do stupid things when you're an undergrad. You know those things you did. You won't know, but you know you did them. That's why you do them, because you're like, well, it seemed like a good idea. But who did you ask? Your friend, who is in the same boat as you. Yeah, great, good, that's a fantastic idea, let's do it. And then you call your parent. Actually, what happened was we were going to, and then it ended up, so you know that's a bad story, right? So, but it's because developmentally, the things that should be making sense are not. And so when you ask them why they would not dose properly, why they would eat pizza and drink a beer without dosing, they're like, well, I mean, I figured, like, I mean, is it really gonna hurt me? Actually, yes, it could hurt you, but it's like the way that they put it together, they're just not making those connections, right? So you gotta be thinking about that. You wanna also increase their sense of agency, because that same kid, you also want him to be able to name the things that he needs, like to be able to own those things and say, you know what, I need to do this, and I know I need to be able to advocate for myself so that my doctor sees me as 18 and not 12, right? Because sometimes doctors can be a little protective, you know. That, you know, I remember that with my younger brother. He had the same doctor, since birth, and they wanted to transfer him when he turned 18 because they said, well, peds is done when you turn 18, you're out of peds. And that was it was a difficult transition for us because he was like a part of our family. Because we had been under his care, interesting. My brother had been under his care for all of his life. I mean, he felt like a member of our family. And so he made choices around his health and his treatment that were probably overly cautious because he was actually invested in us too. He cared about us as like an extension of his family. And so some of the things that other doctors would have been a little bit more progressive around how they did some things, and he wasn't. And so, you know, of course, at 18, you don't have the words, or you don't have the knowledge to understand that. But when you look back on those things, you're like, we really needed a MFP. Like, there were the people who were this, like, don't get me wrong, the medical professionals, they did their job. They did a fantastic job with my brother and my parents. They did what they could do. And we needed somebody else with a different set of skills to be able to help not only us, but how to help my parents be able to ask for the things that they needed when they needed them, right? And that's part of what happens, that we as MedFTs are able to help our clients and patients be able to do that. And the last one is that, you know, you kind of leave the door open for future contact, because you're talking about this is a chronic disease. They're going to be living with it. So these will be patients that you don't necessarily terminate. Because if you're embedded in the family practice or you're embedded in the clinic, whenever they come in, you're going to see them, right? You're there. And it's like, oh, because if you have a really good relationship with the physicians, you meet with them and you know who's coming in to clinic. That's fantastic. So you have the list and you're like, oh yes, that's right, the Smiths are coming, or the Joneses are coming. Oh yeah, that's right, we need to check in on that. And you build your day around being able to check in with those families to make sure things are okay with them. And if there are new patients, you have time to be able to work with the new patients too. That's like the dream place to be, right? Because you've got the doctors who understand why you need to be present and that you are a part of the medical team and not the addition that you're, well, yeah, if you go down the hall, past the elevators, yeah, their office is there. No, you're co-located, you're in the actual hub. And so there's a nice warm handoff that they're like, yes, and this is, when you're introduced, you're part of the team. Not, it's just like for these families and kids, there's always a diabetes educator. They always know the nurses, they always know the docs, and they always know the family therapist. So whenever they came in, they always knew who I was. Whenever they would come back, I always make it a point to see them for their 3-month checkup. Checking in to see how things were doing. The parents, and especially the sibs, that was the soft spot for me. Is that I wanted to make sure their siblings were okay and that they were attended to. Okay? Anybody have any questions about these? Yeah.
When it comes to kind of the responsibility of the medical family therapist and scope of practice, how much do you educate yourself on the in the biopsychosocial model and invest time in that? And then also the extra S when it comes to spirituality, how do you address that?
Okay, so the way that so as a biologist, I was definitely all about the systems in the body, right? I knew what it meant when they would say things, I knew what that meant. So I didn't have to do